Hey guys, Miss Hill here, and we are going to be talking about intrapartum care for this module. This is individual module 5.2, and this is PowerPoint 1. Here are your learning objectives, and let's get started. So we're going to start by talking about family-centered care, and first we have to decide what is family-centered care. This is a model of care that is based on the philosophy that physical, socio-cultural, spiritual, and economic needs of the family are combined and considered as a whole when we plan care for the childbearing family. It's very important that we ensure that we're providing family-centered care whenever we are providing care to the childbearing family, because it promotes a successful labor and delivery. It promotes a successful environment for the family to flourish. You can see this picture here where you have kind of a homey looking labor, delivery, and recovery room. They're more like home these days in the hospital. They're a little more comfortable for families, and it just enhances the family environment. So let's always remember that whenever we're talking about anything really dealing with this class or labor and delivery, the childbearing family, that we need to stay focused on family-centered care. We're not only taking care of that mom and her unborn child or her newborn, we're also taking care of the family support system that surrounds her. Moving on. We're going to start our intrapartum series talking about the 5 P's, and these are critical factors during labor and birth. Without these things working together in a way that is conducive to birth, then birth does not happen like it should. So here are the 5 P's. We have the passage, the passenger, the passage-passenger relationship, power, and psychosocial considerations. The passage is the birth canal, as you might expect, and the passenger is the fetus. Number 3 is the relationship between those first 2, the passage and the passenger. Number 4 is power, and this is solely focused on contractions and pushing effort from the mom. And then psychosocial considerations are something that we always deal with whenever we're dealing with any patient. No different here. So, progress of labor depends on how well the relationship between these 5 things play out, and abnormalities in one area can cause significant outcome changes for the mom and the baby. We're going to start talking about passage first. And here are the things included in the passage. We have the maternal pelvis, and we're worried about the size of that pelvis and the type of pelvis it is. Our pelvis has 3 parts. We have the inlet, the mid-pelvis, and the outlet. It would probably help you very much if you researched a picture of a pelvis and figured out where the inlet, the mid-pelvis, and the outlet are. It will just help you visualize pretty much everything that we talk about in this particular section of NUR 113. The cervix is also part of the passage, and the cervix during labor dilates and effaces. Dilation is when the cervix starts to open up, and effacement is when the cervix starts to thin out. The vaginal canal and the introitus are also part of the passageway, and we worry about this particular part of the body's ability to expand and distend to accommodate the fetus that has to pass through there. The introitus is the external opening of the vagina, if you didn't know that term. So all three of these things put together make up the birth canal or the passageway. Here are your Caldwell-Malloy pelvis classifications, and we're going to talk about each type really quickly. So number one, you see here in the top left-hand corner, this is your gynecoid pelvis. This is the most common pelvis. It has a rounded inlet, an adequate mid-pelvis, and an adequate outlet. And this is the most favorable type of pelvis for a vaginal delivery. This is what we really like to see. This type of pelvis lends itself very well to a vaginal delivery. Number two is your android pelvis. This is in your bottom left-hand corner. And this is your heart-shaped pelvis. There's a small mid-pelvis, a small outlet, and this pelvis is not very favorable for birth. The baby tends to descend very slowly through this pelvis, and as the fetal head enters the pelvis, in the android type pelvis, it enters in a transverse manner, or like in a sideways position almost. And it's very common for labor to stop, or just things don't progress very well, because if the baby can't descend completely through the pelvis, then labor doesn't do us much good at that point. So you might, the term for that we use is arrest of labor. Number three is the anthropoid pelvis, and you see this one on your bottom right-hand corner. And the anthroid pelvis is nice and oval shaped. There's an adequate mid-pelvis, an adequate outlet, and this is a favorable pelvis for delivery vaginally. So this one is okay too. Number four is your platyploid, and this is the last one in the top right-hand corner. The platyploid is also an oval-shaped pelvis, but in the platyploid pelvis, the mid-pelvis is very reduced and the outlet is inadequate. So it is not favorable for a vaginal delivery. The fetus enters this pelvis in a transverse position as well and engages that way. And they have a very difficult descent through the mid-pelvis because it is so small. And there is a very great delay of progress at the outlet as the fetus comes through. So this is not favorable for vaginal delivery. So we really like to see gynecoid, and anthropoid is also okay. All right, let's talk about the passenger. And one thing that we have to know about the passenger is that the fetal head is the largest part of the body. The head consists of three parts: the face, the skull, and the cranial vault. And then also on the fetal head, we have to consider sutures. We have frontal sutures, we have sagittal sutures, coronal ones, and lambdoidal ones. The sagittal suture is that suture right down the top of the head between the anterior and the posterior fontanelle. Your coronal sutures are in the front on either side of your anterior fontanelle. And then the lymboidal sutures are in the back on either side of the posterior fontanelle. And the fetal head lends itself very well to something called molding. Molding is the ability of the fetus's head to sort of change shape as it comes down the birth canal. So where you see all of these skull plates and these fontanelles and these sutures, the fetus's head has the ability to sort of move these skull plates on top of each other and, kind of mold itself to fit through the birth canal a little more easily. And that is what we call molding. So whenever you think about a baby with a cone head, this is what's happened. The baby's head has molded itself to be able to come out of the birth canal. Fontanelles are very important in babies. They serve a couple of different purposes assessment-wise. So if we have a fetus or we have an infant, newborn that has just been born, we can assess the fontanelles and determine whether they are bulging or sunken in. If they're bulging, that may mean that the baby has some increased intracranial pressure. If they are sunken in, it could mean that the baby is dehydrated. However, during labor and delivery, the fontanelles serve a different purpose for the RN that is laboring that patient. Because if the baby is head down in the vaginal canal and the nurse or the doctor does a sterile vaginal exam, you can actually feel those fontanelles with your fingers. And as you know, the anterior fontanelle is shaped like a diamond, and the posterior fontanelle is shaped like a triangle. So, if the nurse is checking a mother's cervix and she feels a triangle on the fetus's head, then she knows that she is feeling the posterior fontanelle. And depending on where that posterior fontanelle is in relationship to the mom's pelvis, the nurse can tell how the baby is turned on the inside of mom. So she can tell if the baby is face up or face down, and that helps her to help mom progress through labor more rapidly through utilizing interventions that are helpful. Couple of things that you want to know about these fontanelles. The anterior fontanelle closes around 18 months, and the posterior fontanelle closes up around 8 to 12 weeks after birth. There are a few landmarks on the skull that you need to be aware of, and these are the mentum, which is the fetal chin, the synciput, which is the brow, like right where the eyebrows are, the bregma, which is the anterior fontanelle, vertex is the area between the anterior and the posterior fontanelles, and the occiput is the area beneath the posterior fontanelle. We talk a lot about vertex and occiput. So if we say a baby is a vertex, that means that what you feel is the area between the anterior and the posterior fontanelles. We know that the baby's head down. If you say that, if we're looking for a landmark on a baby, or we're feeling during a sterile vaginal exam for something, the occiput may be another area that we refer to if that baby is head down. So just a couple of terms that you probably will hear often. All right, so also with the passenger, we got to worry about presentation. Presentation is determined by the fetal lie and presenting part. And whenever you say presenting part, that means which part is facing towards the birth canal. Which part's going to come out first is an easy way to remember it. They can be described as being cephalic, which means head down, breech, which means butt down, or shoulder presentations. And we're going to look at some of these. Another thing to remember is that breech presentations and shoulder presentations are also called mal presentations, which basically just means a bad presentation because we don't want anything other than head down if a mom is going to deliver vaginally. So if we have a mal presentation of some kind, then labor is not going to progress like it should. All right. So there are some different types of cephalic presentations, and you may want to know these and be familiar with these photos. So A is vertex. If you look at this baby, you can tell that if you checked this mom's cervix and this particular baby was positioned this way inside mom, what you would feel is the vertex of the head, the area between the anterior and the posterior fontanelle. This is good. We like to see this. Vertex position, the baby is completely flexed. The fetal chin is to the chest, and the smallest diameter of the head is presenting into the vaginal canal, which is really good, right? Because the fetal head is the largest part of the body. And we want to be able to push the smallest diameter through that we can, because that makes it easy on baby and easy on mom. B is a military presentation. And in this presentation, the baby has no flexion or extension of the head, and the occipitofrontal diameter is presenting, which means the very top of the head. In letter C, this is the brow presentation, and in this presentation, the fetal head is partially extended, and the largest anterior posterior diameter is presenting into the vaginal or into the pelvis. The synciput is the presenting part if you have a brow presentation. D is a face presentation, and this is where the fetal head is hyperextended. In this particular presentation, the submentobregmatic diameter is what presents. You guys do not have to know those big words. I just want you to know the pictures and to know what presentation it is. In this particular one, the face is the presenting part. So this is a facial presentation. So now let's talk about some breech presentations. Breech presentations are mal presentations, so this is not what we want to find whenever we're doing a sterile vaginal exam on a mom. We have several different types of breech presentations, complete, incomplete, and frank. Breech presentations occur in 3 to 4% of all births, and the sacrum is the presenting part. And this is the landmark, and it's classified in relation to the position of the hips and the knees. So that's how we tell if it's complete, incomplete, or frank, because we're classifying it in relation to the position of the hips and knees. So this first picture is a complete breech presentation. The buttocks and the feet are what present. In an incomplete breech, the feet are what present, and this can be single or double footling. So what you would feel in this type of breech presentation is a foot. In a complete presentation, you would feel the sacrum. The frank breech, you would feel the buttocks, and that's the only thing that presents. Because as you can see, in frank breech, the knees are hyperextended, so they're not flexed like they are in complete breech. I hope this makes sense to you guys. Let's talk about why this might be dangerous during vaginal delivery. So we never want to vaginally deliver a breech baby. And the reason is because, just as we said a couple of slides ago, the fetal head is the largest part of the fetal body. So we may be able to get everything out of that vaginal canal but the head. So if we deliver everything and then the head cannot pass through the maternal pelvis, we're in some serious trouble. And that mom would have to go for an emergency C-section, obviously. That baby would not do very well. So we never want to vaginally deliver a breech presentation if we can help it. Be familiar with these pictures. This is a shoulder presentation, and what presents here is the acromion process. This is also a malpresentation. Now, let's talk about attitude. Attitude is another term that you need to know whenever you are talking about the passenger. It's determined by the relation of the fetal parts to one another. So, flexion versus extension, basically. Moderate flexion of the head and the arms and the legs is normal, and this is what we like to see. And that should make sense to you because we've talked about that whenever we've talked about the Ballard scoring system, and we've talked about this whenever we've talked about your assessment of a newborn. We like to see extension. We like to see flexion of the baby's parts, the arms and the legs and the head. If a baby is flaccid or extended, that's not a good sign. Their neurological system is not intact if that's the case. So what we like to see are the arms to the chest and the legs pulled up to the abdomen. Another new term, fetal lie. We have a couple of different types of fetal lie. We have longitudinal and transverse. This is determined by the fetus's cephalocaudal axis in relation to the mother's cephalocaudal axis. And cephalocaudal axis basically means the spine, pretty much. So we can have longitudinal or transverse. And I realize these pictures are blurry, but if you'll bear with me, in picture A, you can see that the baby is up and down. So basically the baby's spine and the mom's spine are pretty much parallel to each other. In picture B, you see the fetus is sideways or transverse. And in this particular photo, the baby's spine or cephalocaudal axis would be perpendicular to mom's spine or cephalocaudal axis. Okay, so we've talked about the passage and we've talked about the passenger. So now we've got to talk about the relationship between these two. And we have three focuses whenever we talk about the passage-passenger relationship. We talk about engagement, station, and fetal position. Engagement occurs when the largest diameter of the presenting part reaches or passes through the pelvic inlet. This can occur weeks before labor, or it can occur during labor. It just depends. Whenever you hear somebody say, my baby's dropped, or the nursey term for that is lightening, this is probably what's happened. The baby has probably engaged in the pelvis. So that means the largest diameter of whatever the presenting part is. In our case, we hope that it's the head. There are a couple of different terms that go along with engagement. Syncliticism versus asyncliticism. And what this means is, where is the sagittal suture in relationship to the maternal symphysis, pubis, and sacrum? And we'll talk about why this is important to know. So the sagittal suture, you got to remember, is that suture between the anterior and the posterior fontanelle, so that one right down the middle of the head. So where is that suture in relationship to the symphysis pubis and the sacrum of mom? We all know the symphysis pubis is on the top of the mom's pelvis or anterior, and the sacrum would be posterior. So syncliticism occurs when the sagittal suture is midway between the symphysis pubis and the sacral promontory. Or the tailbone, basically. And asyncliticism occurs when the sagittal suture is directed either toward or above one or the other of those, the symphysis pubis or the sacral promontory. Basically, it's misaligned. And why this is important to know during exam is because if the baby is asynclitic, then it can interfere with the descent through the pelvis. It can lengthen the process of descent, and it can also lead to the inability of the head to pass through the pelvis because it's just not lined up correctly. So now let's talk about station. Station is determined by the relationship of the presenting part to the ischial spines. So the ischial spines are the two little, they're two little bumps on the inside of a mom's pelvis. And whenever you do a sterile vaginal exam, you can feel those ischial spines. If you do not know or you do not remember the anatomy of a pelvis, it will be very difficult for you to understand all of these things. So you really need to research the anatomy of a pelvis and know that to be able to understand this information. So if you do not, go back and take your anatomy books out or research the anatomy of a pelvis so that you know where things are. So the ischial spines, whenever we're talking about station, are at 0. Oh, goodness. If the presenting part has reached the ischial spines, then the baby is at 0 station. If the baby is -1, -2, or -3, then it's that far above the ischial spines. Anything that's positive, so +1, +2, +3, then that means the baby is closer to delivery. The ischial spines mark the narrowest point in the maternal pelvis. So if we can get a baby to the ischial spines, if we can get that presenting part there to the ischial spines, and we can start moving that baby past 0 station into the +1, +2, +3 range, then it is very, very probable that we will be able to vaginally deliver the fetus. Fetal position is another term that's determined by the relationship of a landmark on the presenting part in relationship to the front, back, and sides of the mother's pelvis. Some of these passenger relationship landmarks include the occiput, the mentum, the sacrum, and the acromion. We've already talked about the occiput and the mentum. Remember, the mentum is the chin, and the occiput is the part on the fetal head that is below the posterior fontanelle. The sacrum, obviously, is the butt, and acromion is the shoulder. And then we also have landmarks on the maternal pelvis, and these include the right, left, anterior, posterior, and then transverse. So anterior would be the top of the mom's pelvis. If she is lying down in front of you, anterior is the top of her pelvis where the symphysis pubis is, that side of her pelvis. Posterior pelvis would be where the sacral promontory is, so the bottom side of her pelvis. The right and the left, don't get those confused with your right and left. Whenever we're talking about assessment things, we are talking about the right side of mom's pelvis or the left side of mom's pelvis, not what side you are assessing from. So just remember that. Couple of things to note. If the landmark that we are talking about is the occiput, then the baby is in a vertex presentation. If the landmark we're talking about is the mentum, then the baby would be in a face presentation. And obviously sacrum is breech and acromion is shoulder. So let's look at some of these pictures. You will see these again, so pay close attention. All right. So I only want you to worry about vertex positions for now. Remember, if the baby is presenting vertex, the landmark that we focus on is the occiput. And what is the occiput? The occiput is the part on the fetal head that is below the posterior fontanelle. Okay? Remember that I told you on a vaginal exam, you can feel fontanelles in the fetal head. So if we do a vaginal exam on mom, then what we search for as a labor nurse is this landmark right here, the posterior fontanelle. And we know it's the posterior fontanelle because we can tell that it's shaped like a triangle. And what we look for is, where is that landmark that posterior fontanelle in relationship to the mom's pelvis. So here's the anterior, this is mom's legs, and this is the baby coming out of the vaginal canal, the head coming out. So this is the anterior of the pelvis, and here's posterior of the pelvis, and here's maternal right, and here's maternal left. Okay? All right, so we're feeling for the posterior fontanelle, which is here, and we can divide this mom's pelvis into basically a grid, into 4 sections. Where'd my mouse go? Okay, so if we divide it in half this way, from front to back, and then we divide it in half from side to side this way, what quadrant does our posterior fontanelle fall in? In this case, it falls in the left side, mom's left, the left side of the posterior section of mom's pelvis. So we would call this baby LOP, left occiput posterior. The L, the first letter, stands for either mom's left or right. The middle letter stands for the baby's presenting part, so the occiput, if we're in a vertex position. And the P, the T or the A, stands for either posterior pelvis, transverse, or anterior pelvis. Okay, and this P right here that you see in the very last one, that is supposed to be an R, so that should be right occiput anterior. So let's just go through these really quickly so that you can write them down. LOP stands for left occiput posterior. ROP, right occiput posterior. LOT, left occiput transverse. ROT, right occiput transverse. LOA, left occiput anterior. And ROA, right occiput anterior. Okay, so what we're looking for is the posterior fontanelle, and we want to know what quadrant is that posterior fontanelle in. We divided pelvis into 4 quadrants. Okay, so let's do another one. Transverse. Let's look at transverse. Transverse basically just means that the baby has entered the pelvis in a transverse position. The baby's head is sideways, so the baby's face is either looking directly left or directly right. If the baby is posterior, meaning the posterior fontanelle is to the posterior side of the mom's pelvis, or the posterior section of mom's pelvis, the baby's face up. If the baby is anterior, meaning the posterior fontanelle is towards the anterior side of the mom's pelvis, then the baby is face down. Now, think about how with any vaginal birth that you've ever been able to see, what way did the baby come out? Usually, babies come out face down. And that is because it is much easier for a fetal head to pass through the maternal pelvis in an anterior position. Doesn't matter if it's left or right, but anterior just lends itself to an easier passage through the pelvis for whatever reason. Babies that are posterior or face up do not tend to have as easy of a descent through the mom's pelvis. Sometimes that labor is long, and sometimes they just don't come down as easy for whatever reason. So the posterior and the transverse positions are malpositions, and they are often related to difficulty laboring for a mom. The occiput anterior positions, either left or right, are the most common positions that you find. And usually if the baby is in an occiput anterior position, the mom will have a normal progression of labor. I know that's a lot of information. Just try to listen to it over and over as many times as you need to, and I'll be glad to help any of you guys if you are still confused. So let's move on and talk about power. Whenever we talk about fat power, we talk about a couple of different things. We are concerned with contractions, and we're concerned with pushing effort or bearing down. So first, let's talk about contractions. Contractions are rhythmic, intermittent tightening of the uterine muscles. And the reason they are intermittent is because that allows restoration of uteroplacental circulation. So this is a respite time for the mother and a respite time for the baby. For mom, she's able to catch her breath. She's able to rest, not having to continue to work so hard. And for the baby or for the fetus, it's a respite period to reoxygenate. Whenever a contraction happens, we are essentially cutting off the oxygen supply to the baby for a short period of time. And so if we continue to cut that off continuously, then we're going to end up with a hypoxic fetus, which is not good. So that's why they are intermittent. Also, if the contraction continues without a respite period in between, then we can build the pressure up in the uterus to a point that the uterus will actually rupture, and that is not good either. Contractions also cause effacement and dilation, and if contractions are effective, then the cervix will continue to efface and continue to dilate until the mom is 10 centimeters dilated and 100% effaced, and at that point she can begin to push. There are 3 phases of a contraction. We have the increment, which is where the contraction builds up. The acme is the peak of the contraction, so the highest point. And the decrement is where the contraction decreases or goes back into a resting tone. And we have a few descriptive terms whenever we talk about contractions. We talk about frequency, so how often are they coming? Duration, how long do they last? And intensity, are they mild, moderate, or strong? So, let me find my mouse. All right, so this is the increment right here. This is the acme. And this is the decrement. Whenever we measure frequency, we measure from the beginning of one contraction, so right here, to the beginning of the next contraction. And that will tell you how far apart they are. Whenever we measure duration, we measure from the beginning of one contraction to the end of that same contraction. And that tells us how long the contraction lasted. Frequency is measured in minutes, and duration is measured in seconds. And now this is an estimate because every contraction will not always end up directly on a line. Every dark line is considered a minute, and each of these little boxes is 10 seconds. So the small lines, or the bright red lines, indicate a minute, and then all of those little lines in between the dark red lines represent 10-second blocks. This is your resting tone, so right here. This rest period between contractions is your resting tone. We have to pay close attention to resting tone in labor and delivery, because if resting tone starts to increase and it does not go back to the point where it was, you can see this resting tone is starting to go up here. See how it's starting to increase some? If this continues to go up, then that mom is at risk for uterine rupture because the pressure continues to build and build. Now, intensity is measured by assessing mom. We have two ways to do that. The most important way is assessing mom's abdomen with touch or feel. We want to palpate her abdomen. If her abdomen at the peak of a contraction feels like your chin, that's a mild contraction. If it feels like your nose, that is a moderate intense contraction. And if it feels like your forehead, that is a strong intensity contraction. So that's how we measure intensity. So here is the intensity of your contraction. It goes from the peak to the resting tone. So that is your intensity. Now, if mom has in a monitor called an IUPC, or an intrauterine pressure catheter, then we will actually measure the pressure in millimeters of mercury. And that goes all the way from 0 up to 100. Just a couple of extra things. With an IUPC, the normal resting tone would be anywhere from 10 to 12 millimeters of mercury. So that's what we would normally see if we have an IUPC inserted into mom's uterus. Another thing is that if a mom is in early labor, the IUPC will pick up contractions that should be anywhere between 25 to 40 milligrams of mercury. Once she reaches active labor, those contractions become a little more intense, and they will measure anywhere from 50 to 70 millimeters of mercury. And then when she hits the transition phase of labor, her contractions will be most intense, between 70 and 100 millimeters of mercury. And we're going to talk about stages of labor in a minute. This is a little video. You can watch it on your own. So the next thing we have to talk about whenever we talk about power is pushing effort. And pushing effort or bearing down for a mom happens when the cervix is completely dilated and effaced, so 10 centimeters dilated and 100% effaced. So dilation we measure in centimeters, and effacement we measure in percent. It's an active response from the mother to help with the delivery of the baby. We have a contraction of abdominal muscles paired along with the uterine contractions, and this helps expel the baby. It helps push the baby through the vaginal canal and into the outside world. The effectiveness of your pushing effort solely depends on the mom's ability to bear down with enough force to make that effort effective. So if mom has an epidural and she is unable to feel or have an urge to bear down or push, her effort of pushing may not be as strong as it should be. If moms start to push too early, so when the cervix is not dilated enough or not completely effaced, then we can cause cervical edema, tears in the cervix, bruising, and it will also exhaust the mom. So this is why we want to wait until the cervix is completely dilated and completely effaced before we start asking a mom to push and bear down. Psychosocial considerations. Whoa. Several things that we have to consider whenever we're talking about criticals of labor, the critical factors of labor. We got to consider if the parents are ready. Are they fearful? Are they excited? What's their anticipation? What type of level of support do they have? Does mom have some birth fantasies that are not going to play out to how she expects? You know, people come in to have babies and they have these birth fantasies of how things are going to go. They have a picture in their mind of what they believe is the perfect birth, of how they believe things are going to play out. And when things don't play out to the way that they've dreamed those things up in their mind, to how they want them to be, or for how they believe things are going to happen, that can be very disappointing, and it can also put a big emotional stress on them as well. And it will also affect the satisfaction level that they have with their experience. So we have to be cognizant of that. How prepared are the people, the family, the mom that's coming in to have this baby? Is she knowledgeable? Has she done this before? What's her emotional status? What's her culture? And how does that affect how she believes this whole situation should play out? Does she have appropriate coping mechanisms to deal with the pain that she's getting ready to experience, or the whole new life that's getting ready to unfold in front of her? Does she have a support system? Is she an adolescent that has unsure who the baby's daddy is? Is her mom and her dad supportive of what's going on, or is she totally alone? Is the person a prima gravida or a multigravida? It makes a big difference if you've had a baby before. You know what to expect, and you also know a little bit about how to care for them, so you're not as stressed out about caring for something so small and tiny. Birth is a physical and emotional stress, and we have to remember that, and we have to be very supportive of the family and the mom as they go through this. And empowerment and having control over one's body plays a really important role in how mom will view her experience, if she will view it positively or negatively. It's very difficult to lie in a bed and not have control over the things that are happening to you. And if she feels out of control or like she doesn't have a say-so, then her experience will feel very negative to her. So we have to also remember that. All right. Labor onset and causes. So what things cause moms to go into labor? We hope that labor begins somewhere between 38 and 42 weeks, because at that point a mom is considered to be term in gestation. The exact cause of labor onset is unknown, but we have a pretty good idea of some of the things that push labor to begin. Progesterone withdrawal is one of them. Progesterone relaxes smooth muscles, and we know that the uterus is a smooth muscle. So as progesterone withdraws and estrogen begins to surge, that stimulates uterine contractions. So those two things together, the connective tissues of the uterus begin to loosen. We have softening and thinning of the cervix and opening up of the cervix as well. So we stimulate uterine contractions with the estrogen surge, and the progesterone withdrawal helps relax the smooth muscle. Also, oxytocin plays a big role in contractions. Oxytocin is the hormone that is released by the hypothalamus, and it also is released by uterine tissue as well, and it causes contractions. The synthetic form of oxytocin is Pitocin, and that's what we give to induce moms or cause contractions whenever hers are not adequate enough. We have a few initial signs of labor. These are also called premonitory signs of labor. Lightening is one, or engagement. This is sometimes described by the mom as dropping, like we discussed earlier. And this is where the fetus settles into the pelvic inlet. So the presenting part reaches and settles into the pelvic inlet. Braxton Hicks contractions are contractions that are irregular and very intermittent. They have no particular pattern. Moms often describe them as a drawing up sensation. They may describe them as the baby feels like it's balling up. Sometimes they're painful, but oftentimes they're not. They may be a little uncomfortable, and we term these as false labor a lot of the times. Cervical changes happen with premonitory signs of labor. The cervix starts to soften up. It's not as firm, and we call that ripening. You might see bloody show. Bloody show is that mucousy discharge that a mom gets as her cervix begins to change. The cervix is a very vascular structure during pregnancy, and as it starts to change, things start to ripen up, or maybe it starts to dilate and thin out a little bit. You'll get some bleeding and some mucousy discharge. So that mucousy discharge will be bloody streaked. Also, you may see bloody show as a result of vaginal exams as well. Rupture of membranes may occur. With rupture of membranes, your patient will see, or you as the nurse will see, amniotic fluid. Hopefully it's nice and clear, but you got to think about what your priority nursing action is whenever we talk about rupture of membranes. Just like with any other loss of fluid or assessment of fluid that's coming out of the body, we want to record the time that it happened. We want to record COCA, the color, the odor, the character, and the amount. And also with rupture of membranes, we want to assess the fetal heart rate. We know that amniotic fluid provides a nice cushy place for the fetus to live and float in. And also, one thing that floats in that amniotic fluid is the umbilical cord. So if we lose amniotic fluid and we don't have as much left, it's very possible that the umbilical cord could get smashed in some way during a contraction or otherwise, and cause the fetal heart rate to plummet. So we always want to assess the fetal heart rate when anything like that changes. Moms also may get a sudden energy burst. That's another premonitory sign of labor, and this is also called nesting. We talked about this earlier in antepartum. This is when the mom gets this huge burst of energy and she wants to clean everything up. She wants to finish the baby's room. She wants to wash all the clothes. She's like a whirlwind around the house. Also, moms may have possible weight losses due to fluid shifts, and that happens because of hormones. And a lot of the times before moms go into labor, they have GI upset, so they might experience diarrhea and vomiting. Really quickly, we're going to go over true versus false labor, and this will be the end of Lecture 1 for Individual Module 5.2, PowerPoint 1. So, true labor versus false labor. What's the difference? True labor have contractions that are very regular. The mom may experience pain in her lower back or abdomen, and she's got a progressive contraction pattern. Those contractions increase in frequency, they increase in duration and intensity, and the mom can get no relief. It doesn't really matter what she does. Nothing relieves her pain. And also, with true labor, the cervix will efface and dilate. With false labor, contractions are irregular. Pain is mostly in the abdomen and the groin area. We also term them Braxton Hicks. There's no progressive contraction pattern, and relief is possible. So mom can take a warm bath or maybe some Tylenol and some Benadryl. And also with false labor, we have no cervical effacement or dilation. With false labor, the contractions are unchanged with activity. So mom can get up and walk around and it doesn't make a difference. With true labor, that labor and those contractions will worsen as the mom becomes active. So as she's walking around the labor unit or walking around wherever, her contractions become worse and worse. All right, so that is the end of Lecture 1 for Individual Module 5.2, PowerPoint 1. And I will continue in a second lecture. Thanks for listening.